Our essential projections for the L spine would be your AP, the lateral. L5S1 spot is what the lateral L5S1 is referred to, and then AP obliques. The obliques you can take PA as well, but for patient comfort and ease of positioning, we usually shoot AP obliques. And we've got some views for the SI joints, which would include your AP axial, actually, and we'll do some obliques there as well. L-spine views can be performed with the patient upright or laying down, typically supine. If we're shooting upright, then in a lot of cases what we're looking for is weight bearing or possibly bending, and bending differs from flexion and extension in that flexion and extension views are with the patient bending forward or backwards, just like in the C-spine, as opposed to bending views would be lateral bending. And in both of those cases, what we're looking for in a lot of cases is fusion, just like what we were talking about in C-spines as well. So for the AP, our part positioning, we're going to have the mid-sagittal plane centered to the image receptor, which is going to put the mid-sagittal plane perpendicular to the image receptor and parallel to the central ray. Your coronal plane is going to be parallel to the image receptor and perpendicular to the central ray. The shoulders and hips should be in the same horizontal plane, which means that if the patient's laying down, the positioning is very similar to whenever we did a KUB or an abdomen, and that would be to put the iliac crest at an equal distance from the tabletop or the image receptor to make sure that you don't have any kind of rotation on the lower portion of the L spine. So you can have the patient's arms down to their side or up on their chest. Really, it doesn't matter, just out of the way, but I recommend that if you have a blanket on the patient, don't put the patient's hands under the blanket, because what happens in a lot of cases is the patient seeks to get comfortable and they put their hands across their chest or across their abdomen, and in doing so they may put their hands in the way of the x-ray. To reduce lordosis, what we're going to do is flex patient's hips and knees and put the bottom of their feet on the tabletop, and that puts the lower back closer to the table. So central ray is going to be perpendicular to the image receptor, and depending on what size collimated field that you're using and what it is specifically that you're trying to include on the image, your centering could be at L4 or it could be at L3. So if you're using the entire image receptor, your central ray is going to be perpendicular to the iliac crest, so you're going to shoot to L4. If you're using more of like an 11-inch long collimated field, then you might center at L3, so a couple of inches above the iliac crest. A lot of people use maybe 2 to 3 fingers width distance between the top of the iliac crest and the center of the central ray. So your collimation is going to be 8 by 17, maybe 8 by 14 if you're not interested in seeing the lower portion, the sacral portion. So what we're going to look for is evidence of proper collimation, area from the lower thoracic vertebra to the sacrum. So remember, we have to see the adjacent structures. So we have to see the upper portion of the sacrum, and we have to see the lower portion of the T-spine. So regardless of whether you're using a 17-inch long collimated field or a 14-inch long collimated field, you still have to see those things. So with 17-inch, what you're including is more of the sacrum. The collimated field should not cut off the psoas muscles, and we shouldn't have any kind of artifact across the mid-abdomen region from the patient's pants, or if they're wearing yoga pants, or if they're wearing jeans, the snaps or the buttons or the zippers should not be in the way as well. So I really recommend that what you do is dress your patient or put a sheet over the patient and just have them lower their pants down to about mid-thigh. And it's very important to cover them first, because sometimes your patients will get undressed right in front of you. So what we want is no rotation. Our vertebrae need to be symmetric. The spinous process should be in the center of the vertebral column. The SI joints should be equidistant from the vertebral column. We should see open intervertebral disc spaces. We can assess rotation in the upper end by looking at the lower ribs and whether or not we've got some appearance of rotation of those ribs. And we can assess rotation in the lower portion of the L spine by looking at the position of the sacrum inside of the pelvic ring. And then we want to see the bony trabecular pattern in the soft tissue as well. So it should look like that. Now, sooner or later, you're going to run into a test question that asks you about how to perform a frontal view of the L spine and make sure that the intervertebral disc spaces are more open, or what projection you can use to open up the disc space better. And I'm going to kind of draw it out here, but the L spine, even if you bend the patient's knees, you got a little bit of that lordotic curvature. And what that means is that the blockiness of those vertebrae, a portion of the vertebra, are going to be at odds with the divergent central ray. So some of the intervertebral disc spaces are going to be kind of going that way, while the central ray is kind of going this way. And I'm drawing that rather exaggerated. But with a patient in a PA projection, if they're laying prone, then those same disc spaces are going at an angle that's more parallel with the divergent central ray. So we talked about this when we were talking about wrist bones and shooting wrist bones, AP as opposed to PA. You get a better wrist with the carpal interspaces are better demonstrated with the hand supinated as opposed to prone, and the wrist supinated as opposed to prone. But we just don't do them that way. We shoot them PA, and we kind of have the same thing going on here, only in reverse. So to see those disc spaces better, we would be better off shooting PA L spines. But we shoot AP L spines. We bend the knees in order to not have too much of that occlusion or closure of those disc spaces. So again, lateral bending would be for evaluation of fusion. Sometimes it's also used to assess scoliosis. And so scoliosis is a normal deviation, and it occurs more times in young women than what it does in men or little girls, more so than little boys. It's diagnosed in childhood in most cases. So it's a lateral curvature of the spine. So the spine from a frontal view should appear very vertical, but with scoliosis, what you've got is you've got two curvatures. You've got a primary curvature, which usually occurs fairly low, and then you got a secondary curvature where the spine tries to correct itself and move back into a center line type orientation. So sometimes lateral bending can help to assess the mobility of a patient with scoliosis, how well the patient moves. So two things. It can be used to assess fusion or mobility, especially in patients with scoliosis. Really all you're going to do for a bending series is shoot 2 to maybe 3 APs. One, if it's a 3 view, one with patient standing upright, one with patient just bending as far over towards their left-hand side as possible, and the last one with patient bending towards their right-hand side as far as possible. Lateral L spine can also be shot with patient laying down or standing up. If they're laying down, we're going to have some issues, kind of like what we had in the thoracic spine, with it not being completely parallel to the image receptor. So we're going to have to take some steps there to make sure that we don't close our disc space, and maintain a parallel relationship between the disc space and the central ray. With patient upright, that's generally not a problem. Your centering is going to be the same as for an AP, in that our central ray may be to L4 or L3, depending on what you want to include, how much of the L spine of the sacrum specifically that you want to include. Obviously, you're going to roll the patient up onto their side. So put the patient in a true lateral position with mid-sagittal plane parallel to the image receptor. Mid-coronal plane should be vertical with the patient laying down. So it's vertical and perpendicular to the image receptor. Bend the patient's knees and flex their knees and put them in front of them, again, as if the patient's going to sleep. Put their arms out in front of them. Make sure their shoulders are stacked. Make sure their pelvis is truly lateral. Make sure their knees are on top of each other. So if you back up and you take a look at the patient's spine and you see that you've got a little bit of a bend in the spine because of the difference in size between the hips and the pelvis, then you need to build the patient's spine up. So place a radiolucent sponge under the patient's lower spine to make sure it's horizontal. That's if needed. If you got a patient, again, who has no hips, and they're kind of shaped like a tube, then that would be unnecessary. So your central ray is going to be perpendicular to the image receptor. It's going to enter the patient's mid-coronal plane at L4. If the spine is not horizontal, then you're going to need to angle your central ray 5 degrees caudad in men and 8 degrees caudad in women. More in females, because females tend to have broader hips with narrower waists. So in the T-spine, our angulation was greater for men, but in the L-spine, we're going to angle caudad for the L-spine. We angled cephalad for the T-spine. We're going to angle caudad for the L-spine, and our degree of angulation is going to be greater. So your radiation field is going to be 8 by 17. It could be 8 by 14, but most of the hospitals I worked in, both for the AP and the lateral, they wanted 8 by 17. And because we're going to create a lot of scatter radiation, just like in the T-spine, we want to use lead shield behind the patient to reduce the scatter and prevent some of that from striking the image receptor. So we want to see evidence of proper collimation. We want to see the area from the lower thoracic spine all the way down to the coccyx for the lumbosacral spine. If we just use a 14-inch vertical collimated field, then we're not going to see all the way down to the coccyx, but we should see a portion of the sacrum. The vertebra should be aligned down the middle of the image. Shouldn't have any kind of rotation. Rotations can be determined by looking at the pelvis and its orientation to itself. So you should have just almost perfectly superimposed iliac crests. If you see the heads of the femurs, they should be superimposed as well. There may be a little bit of vertical separation between them, but that's because of the divergence of the central ray. There shouldn't be any anterior to posterior separation between your heads of your femurs. You're going to have a difficult time if you just walk into the patient's room and you start to imagine where to put your central ray on an L-spine. First off, you're probably going to have a tendency to want to put it in the middle of the anatomy. And keep in mind that the L-spine is further back in the patient's anatomy. That little bit of a density you're seeing right there, that lighter density than the rest of this out here, is the spinous process. So that's as far back as your L-spine or your body is just a little bit of soft tissue past that spinous process. So it's way back. So you're going to have a tendency to position way too far forward. But if you will look at this density, if you can see this bright area right there, that's your iliac crest. And if you got your patient truly lateral and they don't have any kind of rotation, then what you should see is the peak of that iliac crest being right around the middle of the vertebra. So we go straight up from this, and let's say we take this distance and we flip it over. It's about the same distance between here and here as it is from here to here. So the highest point of your iliac crest is going to be right around the center of your L spine. So what do? You find the highest portion of the iliac crest and the longitudinal line of collimation that goes up and down the patient this way, put it going right through the highest portion of the iliac crest, and you can collimate in quite nicely. And you don't off-center. Very common to miss position for an L spine just based on the patient's body build. So flexion extension can be performed upright or recumbent, as can the bending. But our flexion extension is always going to be performed together. It's always going to be a lateral. The bending is going to be AP. It's going to be pretty difficult to phototime. So what you might want to do is take your lateral first and then turn your phototimers off and set a technique based on what the technique was for your lateral. So if you got a good technique for your lateral, if your S number was good and your image looks good, then turn your phototimers off and just set a technique as close as you can to the technique that was shot with the phototimers for the lateral. And then what you're going to do is have the patient bend forward. If they're on the table, you can kind of have them ball up. But if the patient's standing upright, what you don't want to do is tell the patient to bend over and touch their toes. Because in doing that, where most of that flexion is going to come from is in the hips. So what you want to do is you want to be very specific with the patient. Just tell them to slouch from their lower back if they're standing upright. If they're on the table, then you might just have them kind of ball up into a ball. So we're going to use that again to assess mobility, but also assess whether or not our fusion is taking. So flexion extension views kind of look like this, although they have this patient bent over. This can be done, but you need to understand that most of that flexion, that's not all back flexion, that's mainly hip flexion. Good extension, but our flexion here, our spine is certainly going to straighten out, but you can get a better flexion without having the patient touch their toes. The L5S1 spot is used primarily for women who have broad hips and narrow waists, so usually thin women. And it doesn't necessarily have to be really wide hips. It's relatively wide hips in relationship to the waist. So if you have somebody who's thin, a woman who's thin, then in a lot of cases you won't get an adequate density through L5S1. So the patient position is going to be the same as the L spine, but the difference is that what we're going to do is we're going to collimate down to a small area, and the overall image size is only going to be about 4 by 4. So your collimation here, it shows 6 by 8, but I'm really kind of a collimation nerd, so I'm going to collimate in significantly smaller than that. Again, my image size is going to be about 4 by 4. So your central ray, if the spine is horizontal, it's going to be perpendicular to the midcoronal plane, 2 inches posterior to the superior iliac spine, anterior superior iliac spine, and 1.5 inches inferior to the iliac crest. And that's going to seem really, really complicated, but I'm going to tell you the way to perform this that's very, very simple. And if you haven't built the patient's back up to be parallel to the image receptor, again, you're going to angle 5 degrees for males, caudad, and 8 degrees caudad for females. So all of this, you've got to know 2 inches posterior to the ASIS, 1.5 inches inferior to the iliac crest. But if you take the edge of your hand, the edge of your hand on the your pinky finger side, so your fifth digit side, and you sink it into the soft tissue just superior to the iliac crest, and then you fold your hand down so that your thumb is kind of coming behind the patient's back, and all of your fingers are kind of going across the patient's iliac crest and across their pelvis. Then what that's going to do is it's going to form a V shape between your thumb and your fingers, and that V shape is going to be right there. So what you're going to do is put your hand in, again, right at the edge of that soft tissue where the iliac crest is ends, essentially, so right above the iliac crest. Fold your hand down and put your central ray right through the V that is made between your thumb and your forefingers. And that's pretty much going to put you right into that joint space. And again, you can collimate down to a very small field. Now, what we're going to look for is evidence of proper collimation. Really, all we're looking for in this case is good density at the L5S1 spot, and we want to see the open lumbosacral intervertebral disc space. We want to see no rotation, so no anterior to posterior separation of the iliac crests or the heads of the femur. So what it should look like is that right there. Again, your obliques can be AP or they can be PA. Most techs are going to shoot AP obliques just for simplicity. So central ray is going to be perpendicular to the image receptor. It's going to enter the patient 2 inches medial to the elevated ASIS and 1 to 1.5 inches above the iliac crest. So generally on our obliques, we're not going to be looking for anatomy all the way down to the sacrum coccyx. So in this case, we're going to shoot at L3, and we're going to have a probably a 9 by 14 inch. I don't know a whole lot of hospitals that shoot 9 by 12 inch. How you're going to position your patient is with the patient flat on their back. From a flat on their back position, you're going to rotate into both an LPO or an RPO position. So you're always going to shoot bilateral obliques. So rotate the patient 45 degrees, posterior oblique position. Now some textbooks will tell you that you need to take a good patient history and position the patient more similar to the anatomy above or below, depending on which end of the anatomy the patient has some pain in. So I kind of stumbled through that, but here's what it means, is that if the patient is hurting in the upper portion of their L spine, then you're going to want to position the patient a little bit more similar to if the patient had a lower portion of the T-spine issue. So if you remember, the T-spine oblique was a 70-degree oblique. By the time it gets to the lower portion of the T-spine, it's pretty close to a 45-degree oblique. We have a slow change from the upper to the lower portion of the spine. So it slowly changes from C-spine to T-spine, T-spine to lower portion of the T-spine to upper portion of the L-spine. So if you're looking for the upper portion of the L-spine, some of your textbooks will say to oblique the patient 45 degrees, as opposed to if you're looking at the lower portion of the L-spine, your obliquity needs to be more like 30. In both cases, what we're going to look for is this. We're going to be looking at the zygapophyseal joints on the lumbar spine. We're going to look at both sides. So on both the C-spine and L-spine, the anatomy of interest for the oblique was for AP projections for the C-spine and T-spine. The anatomy of interest was on the upside. So on the C-spine, again, it was the intervertebral foramina. on the T-spine, and that was on the upside, if we had the patient in an AP oblique. On the T-spine, it was the zygapophyseal joint still on the elevated side. On the L-spine, the AP is going to show us the zygapophyseal joint on the side closest to the image receptor. So if we reverse all that and we were talking about hypothetical PA projections, our PA for our C-spine, we see the intervertebral foramina on the side closest to the image receptor. On the T-spine, we see the zygapophyseal joint on the side closest to the image receptor. And for a PA of the L-spine, we're going to see the zygapophyseal joint on the elevated side. So where we see the anatomy is similar on the C-spine and the T-spine. What anatomy we see is similar between the T-spine and the L-spine. Going back up to the lateral projection, that big gaping hole right there is your intervertebral foramina. That's where the nerves come out. But going back to our oblique, the zygapophyseal joint will be demonstrated by that dark line right there. So zygapophyseal joint's here. You don't really see the intervertebral foramina at all. Now, how you're going to assess your degree of rotation on a L-spine and whether or not you've got a good degree of rotation is by looking at the Scotty dog. So you're going to hear a lot about the Scotty dog. So Scotty dog is just the appearance of certain portions of the L-spine through the vertebra itself. So you're looking at transverse processes, you're looking at the pedicle, you're looking at the pars interarticularis, you're looking at the superior and inferior articular processes. So what we're going to be looking at is this. The transverse process with patient in a AP projection, the transverse processes should be projected out on both sides equally, right? So transverse process, transverse process. If this patient were to roll towards their right-hand side, then what you're going to see is this transverse process is going to roll up towards you, and this one's going to roll away from you. So how we apply that to a oblique, you don't really see transverse processes on lateral, but how we apply that to an oblique is if you look, that is transverse process. So we don't see this transverse process, it's pretty much pointing right at us. But we can see this transverse process and it looks like it would be going right to the edge of the vertebra. This electronic image just not real good for showing exactly what I want to see or what I want to show you, but it looks like it comes to right about there. And that's about where you want your transverse process to be, is right at the edge of the vertebra. This one's a little bit further back into the patient, which indicates that, you know, if that was the vertebra that we were looking for, we're probably a little bit over oblique. So what we're looking for is zygapophyseal joint. What we want to use to determine our obliquity is where is the nose. So the eye is the pedicle. You're looking straight down onto the pedicle. The superior and inferior articular processes make up your zygapophyseal joint. So that's the ear is basically the superior articular process, as opposed to the front leg being the inferior articular process. The pars interarticularis is just the it's kind of like the neck, so to speak, just this area right through here. So that's what you want to see on oblique, is the Scotty dog. And this is with a drawing of the Scotty dog itself. Hopefully that helps you to kind of identify the individual parts of it. But what we want to see is evidence of proper collimation area from the lower thoracic spine to the sacrum. This is nothing new here. Zygapophyseal joints closest to the image receptor if the patient is AP. If the patient's PA, it will be elevated, the side elevated away from the image receptor. When the joint's not well seen, the pedicle is anterior to the body, the patient is not rotated enough. and they look 2AP. So when the joint's not well seen, the pedicle is too far posterior, the patient's rotated too much. So what we're going to see is from T12 to the top of the sacrum. But what we want to see, in order to see all of the L-spine without having differences in obliquity, then we need to make sure that the L-spine is parallel to the image receptor. If it's not, then your L1 and L2 intervertebral joint space is probably going to be closed. Just a quick reminder chart of what you see on each one of the obliques. So L-spine fractures, again, we're back to compression fractures in a lot of cases. We'll have, if the patient's in some sort of heavy trauma, if they fell and landed on their butt, then a lot of cases you can have a compression fracture, or you can have subluxation. This would be a non-traumatic subluxation. I think I mentioned this in the anatomy portion. This is what you would call spondylolisthesis. And technically what you've got is a subluxation appearance, but it's non-traumatic, and it's, again, not that much of an issue for the patient. It's usually asymptomatic and an incidental finding. Our essential projections for our SI joints would be our AP axial. That would be that Ferguson method that was before in the slideshow presentation. And then we're going to have obliques, and those are just going to be RPO obliques. So Ferguson method is lumbosacral junction sacroiliac joints, and we're going to have patients supine, and you're going to position the patient just like you would for a KUB or AP of the L spine. Mid-sagittal planes can be centered. Extend the lower limbs in this case, though, or abduct the thighs and place them vertically, because we're going to utilize the central ray angulation. The legs may get in the way. We want to make sure the pelvis is not rotated. Your angulation is going to be 30 to 35 degrees cephalic. You're going to need less of an angulation on males and more on females because of the construction of the pelvis. So Ferguson originally recommended 45-degree angulation, but they backed that down to 30 to 35 degrees. Your central ray is going to enter the patient at the mid-sagittal plane about 1.5 inches above the symphysis pubis. So again, I've beat this to death, and I know that, but I really recommend that you don't palpate the patient's symphysis pubis. The distance between the ASIS and the symphysis pubis is about 4 inches on average. Okay, I know what you're thinking. Well, what if I've got a patient that's really, really tall? Well, most patients aren't just tall in their pelvis. So even if you've got a patient with a longer than average pelvis, that distance is never going to be likely more than 5 inches. So it's really pretty insignificant. If the distance between the ASIS and the symphysis pubis is 4 inches, and you found a halfway point to that, that would be 2 inches. So if we're looking for the SI joints and we're doing an AP of the Ferguson, and we need to center 1.5 inches above the symphysis pubis, then all we have to do is subtract 1.5 inches from 4 inches, and that would be 2.5 inches below the ASIS. Would give you the exact same thing. Your collimated field is going to be about 8 by 10. And what we're going to be looking for is evidence of proper collimation. We're going to be looking at the lumbosacral junction and the sacrum itself. We're going to be looking at open intervertebral disc space between L5 and S1. We're going to look at both SI joints and bony trabecular patterns. What we're looking for here is you look at the angulation of the sacrum, and the iliac wings are attached to that. So what we're trying to accomplish is to put our central ray perpendicular to that junction between the sacrum and the iliac wings. So what we're trying to do is angle our central ray perpendicular to that. And that's what we should get. And in doing so, what we should see is the SI joint. That's a dark line that you're seeing right there. Your SI joint is your sacroiliac joint, and it should open it up. Notice that you've got the anterior pelvic bones projected higher on the sacrum. On a KUB, really you see the coccyx right down here, overlapping the very upper portion of the symphysis pubis. But you got a significant portion of the sacrum over the symphysis pubis. So you got your AP, and you also have some obliques that we can do for the SI joints as well. We're always going to shoot these AP. I've never seen or heard of anybody shooting PA SI joints. The sacrum sits on the medial anterior surface of both iliac bones. So in order to see the joint space in between them, what we have to do is oblique the patient up so that we're shooting the central ray through where that junction is. So again, looking at the AP of the L spine, you can see the SI joint, but this SI joint, the sacrum itself is sitting on top of that bone. So the joint space is really kind of at an angle to the central ray. To best open that up, what we're going to have to do is oblique the patient up. So looking at the AP of the L spine and imagining a patient obliquing themselves up, this SI joint is going back into the bone kind of that way. So if we oblique this patient up into what would be an LPO position, because this patient that's the right-hand side, then what's going to happen is the distance between your iliac wing and your ASIS, which would be right about here, this is going to oblique upwards. So the distance between your L spine and that ASIS is going to decrease. And that's what you want to use in your positioning. So you don't want to oblique the patient up so far that the ASIS is projected over the SI joint. You just want to oblique the patient up enough to bring the ASIS almost to the SI joint. What that's going to involve is a 25 to a 30 degree oblique position. So oblique the patient up 25 to 30 degrees. Project your central ray just about an inch medial to the elevated ASIS. And what you're going to visualize is the ASIS on the side that's elevated. So it's going to be the side furthest away from the image receptor. So your LPO shows you the right SI joint. Your RPO shows you the left SI joint. And we're always going to do bilateral obliques. So you may have to support the patient's body. You may have to put a sponge behind them or pillows or something to keep them into position. So we should see collimation. You shouldn't have a 14 by 17 inch image receptor size or collimated field to see SI joints. You want to see the joint of interest in the center of the radiograph, and you want to see the trabecular markings and the bony markings. And it's going to look like this. So you got an SI joint right there. And we're going to have some views of the sacrum and the coccyx as well. And really, if you remember back to when we were doing feet and toes, the similarity between the feet and the toes and the angulation on the feet and the toes were so similar that you might have had a tendency to confuse them. You're going to have a tendency to do the same thing here as well. So your AP sacrum and your AP coccyx, in both cases, you're going to have patient supine. You can do it prone, but I've never seen that happen. So supine, just realize that if you did it prone, everything would be reversed. Your angulation would be reversed. So mid-sagittal plane in the middle line of the table. Mid-sagittal plane would be perpendicular to the image receptor, perpendicular to the image receptor. Mid-coronal plane would be parallel to the image receptor. Get the arms out of the way. You can support the knees If you wanted to, just don't bend them up too much, just maybe a pillow underneath the knees. So for the sacrum, what you're going to do is you're going to center your central ray 2 inches above the symphysis pubis, and you're going to angle your central ray 15 degrees cephalic. So 2 inches above the symphysis pubis. Again, the average distance between the symphysis pubis and the ASIS is 4 inches. So what's 2 inches above the symphysis pubis? The same spot as 2 inches below the ASIS. And then if you were to, for whatever reason, shoot this prone, then your mid-sagittal plane is going to enter at the level of the sacral curve and exit at a point about 2 inches superior to the symphysis pubis. So this is where it's going to get confusing, because for the AP coccyx, you're going to angle the central ray in the opposite direction with almost the same degree of angulation at the same point. So for the AP of the coccyx, you're going to angle 10 degrees caudad instead of 15 degrees cephalad. You're going to angle this for the AP, you're going to angle 10 degrees caudad, also 2 inches superior to the symphysis pubis, which again is 2 inches inferior to the ASIS. If you were to shoot at PA, then it would be 10 degrees cephalic, and it would enter just at the coccyx itself. Now, the reason for the difference between the two, we'll look at the images here in a minute, and you'll see the reason for the difference between the two. If we're looking for the coccyx and we use a cephalic central ray angulation, we're just going to cover the coccyx with the anterior pelvic bones. I'll give you a second to read through that. Basically, it's the same stuff as what we've seen before. You want to see the bones, you want to see the bony trabecular patterns, you want to see the bones of interest in the middle of the image receptor without rotation. But it should look like this. So again, you've got coccyx right there, and it's completely superimposed by the symphysis pubis. If this patient didn't have such a severe gas pattern over the sacrum, then what you would see are the open holes in the sacrum itself. For the coccyx, what you should see is the coccyx without that superimposition, so the coccyx is here. In a lot of cases, when sacrum and coccyx views are ordered, they'll order both sacrum and coccyx. So you got to shoot the APs or the PAs separate, but you can include the laterals on a single view. Again, we're going to roll the patient into a true lateral position and position the patient just like we did for lateral T-spine, lateral L-spine, L5S1 spot, and that is to put the patient's knees in front of them superimposed, and make sure the pelvis is stacked and the femoral heads are stacked on top of each other as well. So your positioning of your central ray is going to be perpendicular to the ASIS at a point 3.5 inches posterior, and that's if you're just looking for the sacrum. I'm not real sure where the recording paused, but it did. So I'm having to back up a little bit, and hopefully I backed up far enough, hopefully. Just to review, just to be sure, on our Ferguson method, which is our AP of the SI joints, we're going to angle our central ray 30 to 35 degrees cephalic to a point 1.5 inches above the symphysis pubis, which is really just 2.5 inches below the ASIS. We're going to collimate to 8 by 10 so that we see those open joint spaces here. We're also going to do obliques of the SI joints. They're always going to be bilateral obliques, and what we're going to do is oblique the patient 25 to 30 degrees into an LPO or an RPO position. We're going to see the open SI joints on the elevated side. So 25 to 30 degrees AP oblique, and we're going to see the elevated side. It should look something like that. So your central ray is going to be about an inch anterior to the elevated ASIS. We have sacrum and coccyx. For sacrum, we're going to do AP and lateral. Coccyx will do AP and lateral. In a lot of cases, these are done together, so the lateral can be combined into one. The APs can't, because we're going to have opposite angulation for the sacrum and the coccyx. In both cases, we're going to have a patient laying flat on their back. You can bend the knees a little bit, but just don't get them in the way. So don't over bend the knees, because we're going to angle cephalic and they could get in the way. Just enough to relieve some of that pressure on the patient's back. We're going to make sure that our ASIS, both of them are equidistant from the image receptor. Make sure you get the arms out of the way, support the knees if the patient's laying down. You can shoot these PA. Never done it before. Never worked in a hospital where that was routine. So for the AP sacrum, you're going to angle 15 degrees cephalic, and that would be 15 degrees caudad if the patient was prone. But where you're going to enter is at 2 inches superior to the symphysis pubis. So again, the distance between the symphysis pubis and the ASIS is about 4 inches. So 2 inches is right in the middle. Instead of finding the symphysis pubis and centering 2 inches above that, what I recommend you do is find the ASIS and center 2 inches below that. So 2 inches below the ASIS with a 15-degree cephalic angulation with the patient supine. If for whatever reason you're shooting with the patient prone, it would be caudad. So your coccyx is going to be positioned exactly like the sacrum, but what you're going to do is you're going to use a 10-degree caudal angulation at exactly the same spot. Now, you can't include these on a single view, because what you're going to see with the sacrum is the coccyx completely superimposed by the anterior pelvic bone, so you're not going to see it at all. So you'll have to shoot separate sacrum and coccyx. You're going to have a tendency to confuse the projections, because the central ray angulations are almost identical. It's 15 degrees for the sacrum and 10 degrees for the coccyx. But for the sacrum, it's going to be a cephalic angulation as opposed to the coccyx being a caudal angulation. So what you get with a caudal angulation on the coccyx is the projection of the anterior pelvic bones below the coccyx, so that you can see it all by itself. On the lateral, you're going to position the patient just like you would the lateral for the chest, or for the T-spine, for the L-spine, L5S1 spot, and that is to put the patient in a true lateral position, arms out in front of them, knees superimposed, pelvis perpendicular, the femoral heads stacked on top of each other. So good lateral position. For lateral sacrum, what you're going to do is you're going to find the ASIS, and you're going to position the central ray about 3.5 inches posterior to the ASIS. If you're looking for the coccyx all by itself, then what you're going to do is, because the coccyx is distal, you're going to go 3.5 inches posterior to the ASIS, but then you're going to move the central ray down the patient's body about another 2 inches to find the coccyx. In a lot of cases, again, you're going to shoot a sacrum and a coccyx series. So what you're going to do is you're going to shoot an AP of the sacrum, and then you're going to shoot an AP of the coccyx, and then you would do a lateral just of the sacrum with the central ray, the collimated field opened a little bit longitudinally, so that you can include the coccyx. So you can do that on a single view. So lateral sacrum with coccyx, lateral coccyx all by itself. So scoliosis. Scoliosis is abnormal lateral curvature of the spine, generally traumatic, or not traumatic, generally congenital. And it may progress with age or you may have some scoliosis because of compression fractures later in life, but that's not true scoliosis. True scoliosis is a childhood thing, and it affects little girls more than what it does little boys. So you can shoot in PA or AP. We prefer PA because it uses, in the PA projection, the central ray passes through the patient's body, and the body acts as a filter before the X-ray beam gets to the patient's breasts. So again, we're talking about little girls to young women that we're shooting, and the breast tissue is very sensitive to radiation, so we want to shoot PA. We want to do whatever we can to save some of that breast dose. So our scoliosis series, if we're truly doing a series, is probably going to be a PA from the neck all the way down to the sacrum and coccyx. It may include some lateral bending. Most of the time it's going to be upright, and it could be upright with or without bending, but we can also do some recumbent views as well. So what we're trying to establish and determine is the amount of curvature in the spine. So they may request views with patient standing and some views with patient recumbent so that we can see exactly how much gravity is affecting that. And if it's bad enough, then what they can do to straighten the patient's back out is to put what they call Harrington rods into the patient's back. What Harrington rods are these big, long rods that attach to, let's say, the transverse processes of certain spinal vertebrae, and they go all the way up T-spine, and they attach to T-spine transverse processes somewhere else. So it completely removes an awful lot of flexibility in the patient's back, but over time will straighten the patient's back out some. So in scoliosis radiography, the bending studies are used to differentiate between primary and compensatory curves. Anytime you have scoliosis, what you've got are two different curves. Your body seeks to be centered over your pelvis. So if your spine curves in one direction, that would be your primary curvature, and then your posture and your body wants to correct for that by bending in the opposite direction. That's a compensatory curve. In scoliosis series, what we'll want to see is a region from the upper portion, possibly from the upper portion of the C-spine, but certainly the upper portion of the T-spine, all the way down to the lower portion of the L-spine, and probably the upper portion of the sacrum. So what that's going to require is multiple images put together. And in screens and films, and in some radiography departments, what you'll see is one very long cassette that holds multiple films that are attached to each other, or one image receptor that's extremely long that will allow for a single exposure to record all that tissue. So from all the way from the C-spine all the way down to the sacrum coccyx. And if they don't have that, then what you might see in clinicals is a single image receptor that moves incrementally. So you might have to take maybe 3 x-rays. So you take one x-ray of the C-spine with the upper portion of the T-spine included, the second image of the lower portion of the T-spine with the upper portion of the L-spine included, and a third image with the sacrum and coccyx and the rest of the L-spine included in that. And the computer can stitch those together to make it look like a single image. It's what they call a stitching program. Regardless of what our equipment will allow us to do, our projections are, for the most part, going to be the same. Upright with the patient facing the bucky, we're going to use the PA projection to save patient dose. We're also going to use what they call a trough filter, and a trough filter is not really a filter like what you generally think of a filter as being something that um, removes low energy X-ray photons. But what it is really is a very thick and um, long piece of aluminum, very thick aluminum. So it's in kind of a wedge shape like that, and it's actually two of them. So you got one with a big wedge that goes this way, and then you got one with a big wedge that goes this way, so that when you put those on the image receptor, that wedge shape is actually going across the image receptor or across the collimated field or somewhere before it strikes the patient. And say the thick portion of the wedge is out here, thin portion is here, thin portion is here, thick portion is there. So it creates kind of like a trough. That's why they call it a trough filter. And the purpose for that is to reduce the breast dose on scoliosis series. So it's going to be PA projection. PA projection does increase the OID, which is going to increase magnification, and it's going to increase blur, and it's going to decrease sharpness of recorded detail. Yes, all of that still holds true, but really the only thing that we're looking for is the curvature of the spine and not so much the sharpness of recorded detail in the edge of the bones. So it's really not that big of a deal that we lose that sharpness of recorded detail. Trough filters I just mentioned, long filters or long cassettes I walked through a minute ago. So your central rays can be perpendicular to the image receptor. Centering points for each sequence will be dictated by the system you use whenever it has to make multiple exposures and stitch the images together. So it could be 2 or 3 images sequenced. So lateral, again, is with patient upright unless otherwise indicated. Mid-coronal plane is going to be perpendicular to the image receptor. The arms should be out in front of the patient so that they don't lay directly over the spine. Central ray is going to be perpendicular to the image receptor. And again, we're going to have 2 or 3 individual images. And our scoliosis radiography looks like that. It's important not to collimate in too far because with that lateral deviation of the spine, it's very easy to collimate off a portion of the anatomy that we want to see. So collimation is important, but always remember that if you collimate to the point that you have to repeat, then the radiation safety benefits that the collimation would afford are totally wasted, and you've more than doubled the patient's dose, or at least doubled the patient's dose. So scoliosis with bending. Bending is off to the side as opposed to flexion and extension is anterior to posterior. And those will be Harrington rods. Harrington rods are an attempt to straighten out the curvature. So you got a primary curvature, you got a secondary curvature, and the Harrington rods are, again, just intended to straighten out the scoliosis.